I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. If you need surgery or a new medicine, you'll have to check with the insurance company to make sure it's covered. This is the People's Pharmacy with Terry and Joe Graydon.
Insurance companies pay the bills, so it's understandable that they would want to make sure the treatments they cover are appropriate.
In some cases, though, it seems that the default is to deny the claim. Some companies even have a position termed the denial nurse.
Having to arm wrestle the insurance company about claim denials can suck up a lot of doctors' time.
Coming up on the People's Pharmacy, how denials of health insurance claims can interfere with medical care.
In the People's Pharmacy Health Headlines, the connection between your digestive tract and your brain is coming into sharper focus. Scientists have long recognized that the brain can influence the digestive tract. People who have to give an important talk often report butterflies in their stomach. This can even make them nauseated. Now, researchers at UCLA report that the brain-gut microbiome system plays an influential role on mental health. They analyzed the components of the gut microbiota and found certain patterns associated with emotional resilience. People with this balance of microbes in their stool were less likely to report symptoms of depression or anxiety. Their bacteria also appeared to have better energy metabolism, lower inflammation, and more adaptability. According to the investigators, these findings suggest that a healthy microbiome could improve people's ability to face stressful situations with resilience.
The first study of ketamine as an injectable anesthetic was published in 1965. It was a unique medication that offered both fast-acting sedation and pain relief without worrisome respiratory depression, sometimes seen with other anesthetic agents. The FDA approved a branded version of ketamine under the name Ketalar in 1970. In 2002, a study of depressed people undergoing orthopedic surgery found that those who received ketamine as their anesthetic had improvement in their depressive symptoms and suicidal tendencies. Over the last 2 decades, numerous other studies have reported that ketamine infusions can alleviate depression and suicidal ideation. The effect is rapid compared to standard antidepressant therapy. A downside of ketamine treatment involves the method of administration. Infusions must be supervised and monitored by qualified personnel. For this reason, they're often pricey. A new study published in Nature Medicine evaluated an extended-release oral formulation of ketamine. People who received the ketamine pills were significantly less likely to experience a return of their depression compared to those on placebo. The authors conclude that the extended-release form of ketamine was effective, safe, and well-tolerated for people with treatment-resistant depression.
Cocoa contains numerous compounds that have measurable effects on people who consume it. A new meta-analysis of randomized controlled trials published in the journal Nutrients examined the impact of cocoa flavonoids on cardiovascular risk markers. The investigators identified 31 trials that lasted for more than a month and compared cocoa compounds to placebo. Nearly 2,000 volunteers participated in the trials. Cocoa compounds lowered cholesterol, fasting blood sugar, and blood pressure. The researchers concluded the consumption of cocoa showed protective effects on major cardiometabolic risk markers that have a clinical impact in terms of cardiovascular risk reduction.
Peripheral artery disease, or PAD, makes it hard for people to walk more than a short distance without discomfort. In this condition, the arteries that supply the legs with oxygenated blood are narrowed and don't supply adequate blood flow and nutrients. Symptoms include numbness, weakness, muscle cramps, weak pulse in the feet, and cold legs. There are relatively few treatments. Physicians usually recommend lifestyle changes, such as quitting smoking and increased walking. A new study published in Nature Communications demonstrates that a form of vitamin B3 called nicotinamide riboside can improve the distance people can walk. This double-blind, randomized, placebo-controlled trial lasted 6 months. The effects were comparable to those of supervised exercise. These clinically significant results may have implications for other conditions resulting from poor circulation. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. At one time, if a doctor ordered a test, recommended a procedure, or prescribed a medication, the health insurance company paid for it without question. In many cases, standard care didn't require prior approval. Now, though, healthcare insurance claims are routinely denied. Doctors may have to spend valuable hours negotiating with the insurance companies so their patients can get the care they need.
To learn more about this complicated and controversial topic, we turn to Dr. Elizabeth Rosenthal. She's editor-in-chief of Kaiser Health News. Before joining the organization, she spent 22 years as a correspondent with the New York Times. Her book is An American Sickness: How Healthcare Became Big Business and How You Can Take It Back.
Welcome back to the People's Pharmacy, Dr. Elizabeth Rosenthal.
Hi, thanks for having me.
Dr. Rosenthal, there was a time, and it doesn't seem that long ago, when doctors decided the best or hopefully the most appropriate care for their patients, and no one questioned their judgment. Now, though, insurance companies second-guess physicians all the time. You wrote an article, I believe in the Washington Post, titled Denials of Health. Insurance claims are rising and getting weirder.
Yeah.
So, why are they rising, and what do you mean getting weirder?
Well, I think they're rising because obviously healthcare is a bit of a money grab, right? Insurers are always suspicious that providers are ordering things that are not necessary, and providers in some cases are, which is why insurers have this idea of pre-authorization, but it's kind of become a monster in that now you have to get pre-auth for smaller and smaller things, and there are more and more denials, and they are getting weirder. We had one instance of a baby who was denied, a neonate who was in the neonatal intensive care unit, and the baby got a letter from the insurance company saying, "We've denied your last stay in the NICU because you were taking milk from a bottle and you were breathing without a ventilator." And this was sent to a 3-month-old. So, of course, a person didn't write that. And I think that's part of the reason they're getting weirder, is because a lot of this is automated at this point, the first round of review. And then, it's become this kind of stepwise process where first, maybe a machine reads the request for a procedure or an operation or a hospital stay. Then a nurse does. Then it goes up to a doctor who's not a specialist in the field. And then finally, it goes to what's called a peer-to-peer review, which means a doctor who is specialized in the same field of the request. So it's It's just become a many-headed hydra that delays care. And I can tell you like a little example from just this morning. My husband has cancer and he was having some trouble breathing and his oxygen saturation was low. And, they couldn't do a chest CT right away because he didn't have pre-authorization. Now, clearly they were going to authorize that, but everyone is terrified now because if you don't have pre-auth, they might not pay, right? So we're waiting around now with someone who clearly needs to get a CAT scan and who won't get it for some hours because the insurer hasn't weighed in. So how's that for, today's example of pre-auth?
Oh, well, it seems to me that pre-auth is, it's not completely unreasonable for the insurance company to say, if you're having a hip replacement or a knee replacement, this is something that you plan ahead for, and it's expensive, so we need to know that that it's appropriate. But when you're in an emergency situation,
Yeah.
that seems unreasonable.
Yeah. And I think, this is like so many things that are terrible in our healthcare system. Yet another example of, the road to hell is paved in good intentions. So, of course, originally the idea of pre-authorization was good. You want to make sure that the person really needs a hip replacement, that if they're getting a knee replacement, they've perhaps lost some weight to make that knee replacement last better. If they're getting a cardiac cath, that they need that rather than a stress test. So it was a good idea. And then it just grew and grew and grew as a device to basically deny care. And that's what's happened now.
Dr. Rosenthal, in your article in the Washington Post, you describe Dean Peterson of LA. He had a heart rate of 300 beats per minute, and it was causing him to faint. They denied the procedure that would solve the problem. I mean, that seems counterproductive.
Of course it does, but this is what we're seeing more and more. How could you deny that kind of procedure? Well, and it obviously a heart rate of 300 is a medical emergency, but yeah, how can what can I say to that question? How can you deny it? Because
Well, it was expensive.
yeah, sure, it's expensive, but it's also life-saving, right? So what can you say? It's insane. And that's why I wrote the article, because people are missing needed care. And something that was started to reduce the amount of inappropriate discretionary care is now being used to deny life-saving care. So I can't explain it, right? I can just say that it is happening and it's terrible.
One of the things that you've suggested in your piece is that insurance companies are saving money by using automated reviews. So they can do 50 charts in just 10 seconds, and that they have saved $11 billion last year. That's billion with a B, by using these automated systems. But it seems like automation doesn't have a lot of common sense.
Well, that's how this newborn got, a denial letter from his insurer, obviously. And ProPublica has done some wonderful work at the automated denials at one insurer. And, this is a case where automation and AI, sure, they can produce some efficiencies, but are efficiencies good for patient care? Obviously not. And, just going back to Dean Peterson for a second, his denial letter didn't even acknowledge what his medical situation was. It said he'd asked for coverage for injections into the nerves of his spine, which he hadn't. So, of course, when your heart rate is 300, You don't need injections into your spine. You need a cardiac procedure.
You mentioned one other example, Deirdre O'Reilly. And this woman was an intensive care doctor. Her son experienced anaphylactic shock, needed epinephrine and corticosteroids in the ED in order to save his life. And the insurance company denied coverage because they said it was not medically necessary. What?
Yeah. Well, and the problem is for patients. Obviously, you're going to get that care, right? If you're in an ER and you're at risk of dying. And so people can say, well, so what if it wasn't pre-authorized? Well, the problem is that if it wasn't pre-authorized, then the insurer goes, well, sorry, you owe for that coverage. You owe for that time in the ER. And in that case, it was close to $5,000. Now, okay, Mrs. O'Reilly, sorry, Dr. O'Reilly could afford that, but maybe some people can't. And, and it certainly was worth the life of her son, but, it's a terrible, terrible position to put patients in, and terrible position to put providers in, frankly, because they know the right thing to do, hesitating not because they don't know what's medically necessary, but because they don't want to put their patients in this terrible financial bind. So, you hear this over and over again. A person is getting chemo that they've gotten every month for the last 2 years, and suddenly the next session is denied. Why? Who knows? And you and I both know, I can call my insurer. I'll be transferred around a lot, and they'll say, oh, yeah, we'll review that. And, for appeals take 2 weeks. Well, that's great if you're going to miss your chemo treatment, which, by the way, if you have to pay out of pocket, probably costs $50,000 and up. It's really become a nightmare for patients and for providers who are kind of, oh my God, what should I do?
You're listening to Dr. Elizabeth Rosenthal, Editor-in-Chief of Kaiser Health News. She's a physician as well as a journalist. Dr. Rosenthal is a graduate of Harvard Medical School and practiced emergency medicine in New York City before she became a health journalist for the New York Times. Her latest book is An American Sickness: How Healthcare Became Big Business and How You Can Take It Back.
After the break, we'll find out who's in charge of deciding whether a claim will be paid.
Some insurance companies term the person designated to review claims the denial nurse. That just makes their expectations real clear.
Is there anything we can do individually or collectively to straighten this mess out?
We'll also hear from an oncologist who treats patients with serious cancer.
What's it like to have insurance companies second-guessing her cancer treatment decisions?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This podcast is made possible in part by CocoVia, backed by 20 years of scientific research and the maker of the most proven and concentrated flavanol extract in the market today, Coco Pro Cocoa Extract. Cocoa flavanols are among the most studied plant-based bioactives today and are clinically proven to promote cardiovascular and brain health for the long term, supporting a strong heart and better memory.
Get 15% off your order of any CocoVia product by using the discount code PPOD15. Learn more at CocoVia, and remember that discount code is PPOD15.
These statements have not been evaluated by the Food and Drug Administration. This product is not intended to diagnose, treat, cure, or prevent any disease. Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by CocoVia dietary supplements. CocoVia Memory and Focus is a unique formula made with a blend of ingredients that work together to promote attention and support long-term memory. It supports 5 areas of brain performance in one capsule. More information at cocovia.com.
How is it that insurance companies are allowed to second-guess doctors about what's best for an individual patient? They don't see patients or perform medical examinations, but because they pay the bills, they have an incentive to deny authorization of tests, procedures, and medications.
Shortly, we'll hear from a cancer doctor who has spoken out about the serious health problems posed when an insurance company delays or denies approval for treating a life-threatening form of cancer.
But first, we continue our conversation with Dr. Elizabeth Rosenthal, editor-in-chief of Kaiser Health News. She is a physician as well as a journalist. Her most recent book is An American Sickness: How Healthcare Became Big Business and How You Can Take It Back.
Dr. Rosenthal, who's in charge of deciding whether an insurance company is going to honor a claim or give a pre-authorization or not? You've written that there's a position called denial nurse at some of these companies, which, kind of tells you what they're expected to do. But isn't that like practicing medicine without a license?
Well, a denial nurse has presumably, that's not the name of the position, a denial MD backing them up. But yes, it's a terrible idea, and I laugh when I hear the name of that job position, but it's also a terrible tragedy that it exists because, the first round of many claims or many medical interventions is it's denied. And you and I all know, we both know that this happens because we've experienced it. Then you get on the phone and you file an appeal, and an appeal can take 2 weeks. And, I am very lucky. I have a very aggressive and active HR department backing me up who knows how to go straight to my insurer and say, what on earth is going on here? She needs this medicine, but others don't. And, we tragically get a lot of submissions to our Bill of the Month portal of people who've filed first level appeals, filed second level appeals. They have their doctor file an appeal. Their doctor's office provides more documentation, and it goes on and on and on. And, sometimes the people get what they need or what their physician feels they need. And other times they give up. They just say, I've done what I can. And sometimes that means they'll pay the bill. And other times it means they give up on getting the care they need or their physician feels they need. So it's tragic either way. I mean, in medicine now, we talk about both physical toxicity and financial toxicity. And let me tell you, from the letters we receive and from the submissions we receive to our Bill of the Month portal, they can both be devastating.
Absolutely. I remember many years ago, before the drug Tagamet was available over the counter, we had a mailman who had a pretty serious upper GI problem, and he was prescribed Tagamet, cimetidine.
No, he was prescribed Zantac.
No, he started with cimetidine, and he developed Stevens-Johnson syndrome.
Oh, wow.
Which is, as you know, a devastating kind of immune reaction. His skin sloughed off. He was in the hospital for not days, maybe not even weeks, but perhaps months before he recovered. And the doctors in the hospital attributed the problem, this terrible reaction, to the Tagamet, to the cimetidine, which was available generically, inexpensive. And they suggested that he needed to take a different drug called Zantac. It was still available at that time, ranitidine. And when he got home, he got in touch with the insurance company requesting that they allow him to get Zantac instead of Tagamet, and they denied it.
Yeah.
And he said, well, wait a minute. It put me in the hospital for a very long time. The bill was astronomical, and you want me to go back on that same drug that caused me all of these problems. And they said, well, we're not going to approve the Zantac. So he just bought it out of pocket. He paid for it himself. He said, I can't go through that again. But sometimes it seems as if insurance companies are penny wise and pound foolish.
Of course, that's true, and he was lucky. There was a way, it was something he could afford out of pocket, if it's, a stent placement or a gallbladder stone removal. You can't pay for that out of pocket, right? If your insurance says, no, we're not paying for that, um, what are you going to do? I mean, you can, what they call now, it's escalated, right? You go, okay, I want to speak to your supervisor who speaks to their supervisor. And then you can have a high level, what I call the peer-to-peer escalation. And that often has much better results. I mean, I had a neurologic drug that I needed, and my doctor, thankfully, I have both my insurer, I'm sorry, I have both my HR department and my physician on my side in this one, because it kept getting denied, denied. And finally, my physician asked for a peer-to-peer review with another neurologist who was familiar with this condition. And she immediately said, oh, yeah, of course. But had I not had the wherewithal to make the calls, had a neurologist who was willing to trade phone calls, play phone tag with an insurer for days on end, and an HR department that was willing to push, I don't know if I would have ever gotten that drug. And it wasn't something I could go out and, buy on my own. It would have been unaffordable. So I think there are a few of us who are lucky to have the wherewithal and the resources and the physicians and the HR departments that are willing to fight the good fight. But the fight shouldn't be necessary is my point. Why did my neurologist have to spend, a couple of hours on the phone to get this claim processed? I mean, he certainly has better things to do. He could be seeing patients, right? He could be helping other people. But instead, our physicians and our employers are spending a lot of time on the phone fighting these claims denials.
Dr. Rosenthal, you've just described some of the things that individuals may need to do to address this egregious problem. Is there anything we should be doing collectively to try and get this mess straightened out?
Well, I think one of the things that surprised me is that the federal government doesn't require insurers to file or report what percentage of claims they deny, right? If you're denying over 50% of claims, there's a problem probably with what you're doing, right? So I think that's one thing that I would hope the federal government would start asking for reporting about. Um, what can a person do? It's really hard at the moment. I mean, persistence pays off. I think that's one lesson here. If it's denied, don't just say, oh, I guess I won't get that. But try and enlist. It's really important to enlist the physicians on your care team. And they often, unfortunately, today, hospitals, physicians' offices have people who I would call them approval nurses, approval nurses to fight the denial nurses on the insurance side. So I think you just have to be really dogged about this and hope that it's not for something that, you really need and you can't afford otherwise.
Dr. Elizabeth Rosenthal, thank you so much for talking with us on the People's Pharmacy today.
Yeah, I'm sorry this is such a frustrating subject, but I think it's one that we really need a national remedy for because it's hurting people nationally.
You've been listening to Dr. Elizabeth Rosenthal, editor-in-chief of Kaiser Health News. Her book is An American Sickness: How Healthcare Became Big Business and How You Can Take It Back.
We turn now to Dr. Shika Jain, Associate Professor of Medicine in the Division of Hematology and Oncology at the University of Illinois Cancer Center in Chicago. She's the Director of Communication Strategies in Medicine and the Associate Director of Oncology Communication and Digital Innovation.
Welcome to the People's Pharmacy, Dr. Shika Jain.
Thank you so much for having me.
Dr. Jain, we have just spoken with Dr. Elizabeth Rosenthal about some of the problems associated with pre-authorization from insurance companies. As a physician treating people with cancer, I suspect that you often make treatment decisions that affect their survival. What's it like to have an insurance company looking over your shoulder, second-guessing your recommendations for treatment?
So it is extremely frustrating, and it is really absurd the way that these insurance companies have really started dictating the care we provide, whether it's giving medications, whether it's imaging. These agencies have decided, and they behave as if they know more about the protocols, more about the patient when they're never seeing these patients, and it's very frustrating.
How often does it happen that your treatment plan gets denied?
It's pretty often, actually, that we have to go through this peer-to-peer prior authorization process. It doesn't get denied as often, but the steps and the amount of time that we dedicate to getting these approved takes away time from patient care and from taking care of other things that we need to get done. So while we don't see as many denials, we do see a lot of wasted time.
Well, I wonder if you could give us some examples because, the best way that our listeners will understand the challenges that you are faced with is if you can describe for us maybe a patient that you've had to deal with recently where you had to jump through some hoops to get them the treatment they needed.
Absolutely. I could give you 100 examples of things that have happened in the last few weeks, sadly. I have, for example, a patient who is on treatment for their metastatic cancer. They need to get imaging every 3 months to make sure that the treatment is working. And I had to go through an entire process, a peer-to-peer prior authorization process, where I had to defend my decision to get imaging to see if the chemotherapy the patient was receiving was working. And then that delayed when the patient's CT scan was actually completed. I had another patient who I wanted to prescribe the newest treatment in a metastatic colon cancer patient, wanted to prescribe the latest treatment, and the insurance company said, no, we will not allow you to treat with this regimen, despite the fact it was the best option for the patient. They first made me do a peer-to-peer, then they refused, and the person I was speaking with wasn't an oncologist, couldn't even pronounce the drugs that I was talking about. Patient's insurance denied it eventually. I had to try a different regimen that the patient then had progressive disease on, and then I was able to give this other regimen, but the patient lost many months while I was waiting for him to be able to receive this other treatment.
Dr. Jane, how do you explain this to a patient? Because going through cancer treatment is hard enough on its own, but then to be challenged by an insurance company that would say to the physician who is trying to save your life, well, you're going to have to wait another few months for that image, or you're going to have to wait before we can approve this new treatment that we think is going to be really helpful. I mean, psychologically, that has to be so devastating.
It's absolutely horrible. And the hardest part for us is we are the ones sitting there telling these patients this information, whether it's in the room with them or on the phone, telling patients the treatment has been denied, telling patients that there's going to be a delay in their care. These patients are already anxious, appropriately so. They're often scared. and they're ready to get started with treatment or get their imaging. And it breaks my heart, these conversations I have where I have to explain to a parent why their daughter can't get chemotherapy because the insurance company is not approving what I want to prescribe.
Dr. Jane, you've mentioned a couple of times peer-to-peer, and I wonder if you could tell us first what that is, and second, when you're talking to a, quote, peer, unquote, are you talking to someone who has experience in your field?
What a great question. So a peer-to-peer is a misnomer because what it's supposed to be is if the insurance company has a question about a certain treatment or a certain plan or certain imaging, you're supposed to set up a meeting over the phone with a peer. So somebody who is at the same level as you who can decide if the plan you've put into place is appropriate. Most of the time, almost all of the time for me, I have had discussions with people who do not have the level of training I have in my field. Oftentimes it might be a nurse, it might be a physician who isn't an oncologist. I've had people, as I mentioned, who can't even pronounce the names of the drugs, who don't understand the disease, who don't understand the latest guidelines. So calling it a peer-to-peer is really quite ridiculous because these people are often not peers. They are just somebody who has been hired by the insurance company to decide whether you, as an expert, know what you're doing. And despite the fact I'm triple board certified, talking to somebody who doesn't understand the disease I'm treating and having to explain to them all of this information and then having them decide whether I am right or wrong in the treatment I'm trying to give is the exact opposite of a peer-to-peer conversation.
I wonder, Dr. Jane, if you could share with our listeners what your area of expertise is when it comes to oncology.
Absolutely. So I am triple board certified. I have board certifications in internal medicine, hematology, and oncology. I work at the University of Illinois Cancer Center, and most academic institutions who subspecialize in a specific type of disease site. And so I am a subspecialist in GI oncology. So what that means is cancers of the intestinal tract. So that could be anything from colon cancer to pancreatic cancer, esophageal cancer, neuroendocrine cancers. So anything that can impact your gastrointestinal tract, I am an expert in that space.
You're listening to Dr. Shika Jain, Associate Professor of Medicine in the Division of Hematology and Oncology at the University of Illinois Cancer Center in Chicago. She's a founder and CEO of the COVID-19 Action and Advocacy Group, IMPACT, and she's also founder and chair of the Women in Medicine Summit.
After the break, we'll get an explanation of prior authorization.
With some cancer drugs costing hundreds of thousands of dollars, it isn't surprising that insurance companies want to be cautious about approving them.
Unfortunately, sometimes they just seem to be throwing up roadblocks.
How does Dr. Jane deal with such setbacks?
Having to deal with multiple denials of authorization can put a big strain on a doctor's time.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This podcast is brought to you in part by the People's Pharmacy and our exclusive line of magnesium-rich roll-on deodorants, crafted with years of expertise and community feedback. Our customers rave about their ability to control odor effectively without aluminum. These deodorants are a superior choice for daily health and comfort.
Each is designed to be gentle yet highly effective, providing reliable odor control without aluminum or other harsh chemicals. Plus, they're incredibly easy to use and long-lasting.
As a special offer for our podcast listeners, enjoy an exclusive 20% discount on any size of our deodorant. Choose between the handy 2-ounce scented or unscented varieties or the economical 3.38-ounce unscented version.
Simply visit the body care section in the store at peoplespharmacy.com and enter the promo code POD20, that's POD20, during checkout to redeem your discount. Remember, this promo code, POD20, gives you 20% off your purchase of our top-rated magnesium-rich, aluminum-free roll-on deodorants until August 2024. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible in part by CocoVia Dietary Supplements. CocoVia Cardio Health is offered in both convenient capsule and powder formats, with each serving containing 500 milligrams of cocoflavanols to support heart health. More information at cocovia.com.
We're talking about how insurance companies deal with physicians who may want to prescribe expensive medications or treatments. All too often, the gatekeepers reject an innovative therapy or a treatment that the FDA has not yet approved for a particular type of cancer, even if it has been shown to be effective.
Our guest is Dr. Shika Jain, Associate Professor of Medicine in the Division of Hematology and Oncology at the University of Illinois Cancer Center in Chicago. She's the Director of Communication Strategies in Medicine and the Associate Director of Oncology Communication and Digital Innovation.
Dr. Jain, we hear that the insurance companies require prior authorization, which sounds very bureaucratic and probably is. Can you explain to us what it is?
So prior authorization basically means they need to authorize a drug. So let's say your doctor sends in a prescription for a certain pain medication or a certain blood pressure medicine. In olden days, before prior authorization, if you prescribed the medication, the insurance would decide how much of it to cover and you would be able to pick up your medication. Unfortunately, what happens now with prior authorization is the insurance company needs to go through multiple other steps to decide whether they can authorize you receiving this medication. So that often results in delays in care. For example, I have patients where I will send a pain medication into the pharmacy, and then I will find out that it requires a prior authorization. So then what happens is there's a delay until it goes through the whole process. Sometimes you have to do a peer-to-peer phone call to advocate for your patient and argue that the medication is needed. And then the insurance company decides if they agree and if they'll approve it or if they won't.
In the meantime, the patient is in pain.
Exactly. In the meantime, the patient is in pain and suffering. And so oftentimes when this happens, I will try to find an alternative so that my patients aren't suffering. But sometimes those alternatives are not the best option. They may not be as effective. So when you make a decision as a physician, a lot goes into that decision making. There's years of education and training and experience and expertise that goes into the decisions that we are making. And to have an insurance company without that level of training, without that expertise, make those decisions, it directly negatively impacts patient care.
Dr. Jain, a lot of the medications that are being prescribed these days, just across the board, are pricey. A month's supply might cost $100 or even $300 or $400. And that could be for cardiovascular medicine. It could be for medication to treat diabetes. But when it comes to cancer, it's a whole different order of magnitude. There are new treatments that cost not thousands of dollars, but tens of thousands of dollars, even hundreds of thousands of dollars for a year's treatment. And I'm thinking now about immunotherapy. I'm thinking about CAR T therapy. And I'm guessing that insurance companies will often make it very hard for a physician such as yourself to get the latest and greatest treatment. How do you deal with that, especially if that new treatment really can make a huge difference in a patient's outcome?
Honestly, it results in us spending hours of our time sometimes advocating, whether it's writing appeals, faxing information in, setting up phone calls, and advocating for our patients. And you're absolutely right. There is a huge level of financial toxicity in this country when it comes to healthcare. And cancer care is astronomically expensive. And where I work at the University of Illinois Cancer Center, we have a lot of patients who can't afford that level of care. And so they require insurance to help take off some of that cost. They require us to advocate for them. But the cost is very, very high. And then as you go through this process, it's very frustrating because while the cost is very high, oftentimes the insurance companies don't even approve it. And again, we've heard stories and there's been news reporting about insurance companies just categorically denying everything relating to a certain drug or a certain treatment because of the cost. And that is unethical.
Well, I'm also imagining that there are some treatments where a patient has to contribute a certain proportion, maybe 10 or 20% as a copay. And if the drug costs, $100, well, maybe that's $10 or $20. That's affordable for a lot of people. But if a drug costs $200,000 over the course of a year, a lot of people can't afford $10 or $20 or $40,000 as their copay. What do they do?
Well, we are lucky at our institution. We have programs that help support those patients. Sometimes we reach out to drug companies directly and ask if they can do something to help mitigate some of those costs. There are assistance programs that we can connect our patients through. We have a lot of support at our institution because many of our patients do face those problems, but some patients may not be able to get treatment at other institutions or in other parts of the country because the cost is so high and insurance isn't covering enough of it for it to be affordable for them.
There's another challenge, I suspect, in cancer treatment, and that is there are frequently breakthroughs. I mean, not quite to the level that we'd all like to see, but there are advances. And those advances sometimes are ahead of what I'll call the FDA approval process. So you may go to a conference and some of your colleagues may say, well, we've just tried this new treatment or this combination, and wow, it's making a huge difference in this particular cancer. And you want to prescribe that new approach, that combination therapy, but the FDA has not yet approved perhaps that combination or that particular medication. And as a result, I'm guessing if it doesn't have FDA approval, that good housekeeping seal of approval from the federal government, the insurance companies can say, well, we're sorry, Dr. Jane, that doesn't have FDA green stamp of approval. What do you do then?
So I'll take it even one step further because, yes, if they don't have FDA approval, then it's almost impossible to get those drugs unless the patient is on a clinical trial. But I'll take it one step further in that there are drugs or treatment plans that have FDA approval that have been approved by the FDA but haven't been updated in the guidelines yet because they were so recently out. Like we go to a conference, we find out that this has been approved. It's had dramatic changes and improvement in patients' care, and we all go back to our clinics and want to prescribe the drug. Many insurance companies won't let you prescribe it, even though it's been FDA approved, because it hasn't been updated in the guidelines yet, whether it's the National Cancer Guidelines or in their own internal guidelines. So now, all of a sudden, we have a drug that's FDA approved that we know has made magnificent changes in the overall survival of patients, but we can't prescribe it because it hasn't been updated in the insurance company's guidelines yet. And that is when we get even more frustrated. And then again, we have to advocate for our patients. And going one step beyond that, I know patients who have been on a certain treatment for years, and all of a sudden the insurance company decides they're not going to cover it anymore. So patients, for example, on ADHD medications have had these problems recently. I've had patients who are on certain types of even chemotherapies where they have been stable for years on a certain type of treatment. And all of a sudden you need to go through the prior authorization process, even though the patient has been on a certain drug or treatment plan for an extended amount of time. So this isn't just for those new agents. This is even happening for patients who've been on treatments for a significant amount of time.
Dr. Jane, I think we can all appreciate the frustration when you want to prescribe something that's going to make your patient's life better and longer. And and the insurance company says no. What do you do in that instance?
Well, first I get really frustrated.
Yes.
But what I've started doing, so I do these peer-to-peer calls, and I often, at the beginning of the call, actually, I'll ask the person for their name, and I will tell them, because I want, if you deny this treatment for this patient, I would like the patient's family and the patient to know who is denying this, because I'm sitting in the patient's room, the patient's getting upset at me because I can't provide a treatment to them, but it's not my fault. And so they need to know who to hold responsible for this. I've also told people that, if you really, really are going to deny this, then you need to know that you are going to end up shortening the life of a 26-year-old man. And I say these things not to be cruel, but because I don't think the people who are on the other end of the line truly understand sometimes that the decisions they're making are directly shortening people's lives in certain situations. And I think that they need to be held accountable. And it's frustrating to go through this process. It's frustrating to waste time. They also set up these appointments when you're in the middle of clinic seeing patients. So it's not convenient. They don't work around your schedule to set these up. And I've even had times where I've called to do a scheduled peer-to-peer and the person's not available, or I get put on hold for 30 minutes. So now my patients are waiting in clinic while I am waiting on the phone to advocate for a patient to receive the care that I think they deserve.
Dr. Jane, I'm guessing that many of your colleagues, just like you, are really, really busy, that you have to see a lot of patients in the course of a day, and that by the end of the day, you are absolutely exhausted. And your schedule is not always your own because it may depend upon, various other factors. So trying to work in an appeal or to be put on hold when you have so many more important things that you need to do has to be incredibly frustrating. I suspect also that there are some of your colleagues who say, I can't waste 2 hours today trying to get a medication for just one patient. That's just unacceptable. And they walk away, leaving the patient kind of in the lurch. There's got to be a better way. What can you imagine if you were in charge, how you would handle these kinds of problems?
Well, that's the $1 million question, because we don't have an infinite amount of time to do all the work we need to do. Many physicians even now are taking work home with them, charting at home, documenting at home, doing all of this work at home. So you're right. There are many physicians who say, I don't have time for this, and they walk away. Either they walk away from being able to do it for that patient, or they walk away from medicine altogether, because the immense amount of burden that has been placed on the healthcare workers to do this and to advocate for each patient. I mean, imagine I saw 14 patients this morning. Imagine even half of them needed a peer-to-peer. Now take that and say, let's say it takes 10 to 15 minutes per peer-to-peer. You do 5 of those, you've wasted a good portion of your day. That's several hours out of your day. There isn't enough time to do all of the peer-to-peers that need to be done, especially when some of them aren't going to be successful. So yeah, some people just stop doing them. Some institutions have actually brought in teams to do these peer-to-peers, and they're paying people, and that is their only job. But then when you start talking about physicians who are practicing in more rural areas, in practices where they don't have those extra resources, I mean, it's unrealistic to be able to expect physicians to be able to do that and fight with insurance companies for every single patient. So I don't know what the solution is other than finding a way to make this either peer-to-peers go away, or there is some discussions in some states of having certain physicians who are gold carded, where if they've defended enough peer-to-peers, they can get a pass and they don't need to do them anymore. But then that again punishes physicians who maybe aren't seeing as many patients or who aren't seeing as many of the same type of patients. I mean, this whole process was created to try to save healthcare dollars. But in actuality, it's costing more healthcare dollars, and it's not a good system.
The question I want to ask is one you may not have an answer to. Can you imagine, can you foresee a way that we could change this entire system so that you wouldn't be wasting your time every day trying to advocate?
Well, in an ideal world, I would say get rid of the system altogether because
Mm-hmm.
it's not effective. But I don't think that's what's going to happen. I think there's a couple of different possible solutions. So one, I think if a physician has an active board certification, I think that it absolutely makes sense to not require peer-to-peer or prior authorizations, because when someone assumes that they can take care of a patient, if I am given that responsibility, you would assume that I know what I'm doing. So I think if a physician has maintained board certification, then you should not require them to go through peer-to-peers. I think insurance companies can keep track and say, this particular physician has prescribed many things that seem outside of the regular standard of care, and then pay attention, and maybe those physicians can be contacted, and maybe those physicians need to have peer-to-peers. Or there's, mid-level providers now. There's nurse practitioners or PAs. Same thing, having checks and balances of checking to see, are there more substandard levels of care being provided by certain people, by certain physicians, by certain nurse practitioners, and then having this process available just for those types of people, as opposed to making it a blanket process for everyone. Because by making it a blanket process for everyone, yes, for sure, there are some bad actors that are probably overprescribing or maybe not doing what is standard of care, but the majority of physicians are not like that. So why penalize everyone for the faults of a few? So that, I think, would make more sense in having insurance companies identify people who there are concerns, and then having them go through some extra steps potentially until that's no longer a concern. But even that is not an ideal situation, because then who is going to decide which physicians and which nurse practitioners and which PAs are not providing the standard of care? So I mean, in a perfect world, I would say get rid of the system altogether. But I think that is one possible solution. Another solution that was actually proposed at a conference I was at recently was holding the insurance companies accountable. So physicians get sued when a patient dies, when an error is made, when we have malpractice insurance for that reason. I think if an insurance company denies a patient care, I think that they should be held accountable, and there should be accountability for that, because they are the reason that a patient did not receive life-saving treatment.
Dr. Shika Jain, thank you so much for talking with us on the People's Pharmacy today.
Thanks so much for having me.
You've been listening to Dr. Shika Jain, Associate Professor of Medicine in the Division of Hematology and Oncology at the University of Illinois Cancer Center in Chicago. She's a founder and CEO of the COVID-19 Action and Advocacy Group, IMPACT, and founder and chair of the Women in Medicine Summit.
We spoke earlier with Dr. Elizabeth Rosenthal, editor-in-chief of Kaiser Health News.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
This show is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
The People's Pharmacy is made possible in part by CocoVia dietary supplements, cocoflavanol supplements that support cognitive and cardiovascular health, made with a proven concentrated flavanol extract. More information at cocovia.com.
Today's show is number 1390. You can find it online at peoplespharmacy.com. That's where you can share your comments about today's interviews. You can also reach us through email, radio@peoplespharmacy.com.
Our interviews are available through your favorite podcast provider. You'll find the show on our website on Monday morning.
At peoplespharmacy.com, you can sign up for our free online newsletter to get the latest news about important health stories. When you subscribe, you'll also have regular access to information about our weekly podcast, so you can find out ahead of time what topics we'll be covering. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.